So what I want to try to do is to give an example to bridge some of these gaps between economists and policy decision makers. In the specific case, it's going to be policymakers. So I'm going to take as an example pay for performance, which I think is an interesting topic. Also, everyone talks about it. So if you think about pay for performance as an economist, how can you approach this topic? Well, one thing is that you can use economic theory. That's the ugly mathematical microeconomics. The other one is to look at some empirical evidence and test whether some pay for performance schemes have worked in practice. And the last one, you can just look at what policymakers are doing. So an economist, you tend to get interested in these three dimensions. So what I'm going to argue is that perhaps these three dimensions don't come together as often as they should. So I'm going to try to discuss what these give a brief summary of these three dimensions for pay for performance, and then I'm going to provide one attempt that I have made with a couple of my co-authors on trying to make pay for performance more relevant policymakers by using a specific example of pay for performance, which is the Strock best practice tariff used in the English NHS. Okay, so I'm going to start giving you just a very brief introduction of what the general issues are about. So we increasingly see lots of quality measures developed. So this can be readmissions rates, mortality rates. We increasingly see patient-reported outcome measures. We see some process measures of quality, like in the stroke example, whether a patient is admitted in the stroke unit. And then basically, once this information is there, we can use this in a useful way. So purchasers, providers can make use of this. So one use of these quality measures is to do pay for performance. So what's pay for performance? It means that you can pay and encourage providers to do better quality by just paying for it. So that's what pay for performance is, attaching monetary incentives. But as an economist, quite quickly you're going to ask yourself the question of what is that price? How high should be this price that you give to the providers, to the hospitals? So that's one way to use the quality measures. There are other ways to usefully use quality measures, like internal hospital management, peer comparison, or put this quality measure in the public domain so that maybe this stimulates choice. These are alternatives way to use pay for performance. So I'm going to focus on the optimal price issue. So what is that price that you should set from a policy paper making perspective? So I'm going to start with the three dimensions. So what does the economic theory say first? What does the empirical evidence say? And what do policymakers say about that? So starting with the theory, if you think about the design of that price for pay for performance, well, quite often economists point out the multitasking issue, which is if some quality dimensions are observed and some others are not observed, then you introduce pay for performance, and then some unobserved dimension of quality are going to suffer. I mean, that's the number one critique to pay for performance. Then I think if you're familiar with the health economics literature, we know that the gaming of the statistics can be an issue. And then also the level of aggregation. At what level are you going to put these prices on? Is this incentives going to be tailored at hospitals, so that you give the money to the hospitals, or do you give them directly at the physicians, and there are trade-offs in terms of going for one option or the other one? So I'm going to focus just a little bit more on the multitasking problem. So again, if you're asking the question, should you introduce this pay for performance scheme, and how high should be the price? So again, there is an academic paper which is quite old in Journal of Health Economics that makes that point formally. So if there are some unobserved dimensions of quality that you cannot observe, you introduce incentive schemes. The dimension that is incentivized gets better, but there are some others that get worse. But then the net welfare effect is indeterminate. So how does that leave in terms of the big question of, well, shall we then introduce these incentive schemes or not? So is pay for performance a bad idea? Shall we use low-powered incentive schemes? So you can put all of that in microeconomic theoretical model and get the answer. So the answer in one of the papers looks like this one. An apology for introducing one equation in this presentation, but basically what this says is that this price should reflect the marginal benefit of the quality that you incentivize, and then if there are these distortionary effects due to the multitasking, you should distort that price downwards based on the marginal benefit of the quality that you don't observe. So from the economic theory, that's what the economic theory can offer. It's qualitative, gives some insights, but it relies on some measures of benefits of quality, which perhaps are difficult to measure. So that perhaps that's one limitation of the theory. So one challenge that we pick up in this paper with my co-authors Søren Christensen and Matt Sutton, we want to calibrate one of these theoretical models so that we can actually say to the policymaker, well, under certain assumption, that should be the optimal price. So in that sense, we are trying to bridge that gap between the theory and the policy making by trying to come from the sky, come closer to the decision makers. So before I show you that example, I want to tell you just one slide about the empirical work. So there are quite a lot of empirical studies that try to evaluate some existing schemes that have evaluated the pair for performance. And quite likely there is a recent report by the European observatories which just summarizes all the literature that is out there. So the sentence I put in bold is the summary of the 300 pages report. So it says, current hospital schemes have achieved very limited or no improvement in incentivizing process measure of quality. So that doesn't sound very promising, but there are a couple of caveats. So the caveats are that most of this scheme have involved a price that was around no more than 5% of the revenues. So you could think that this is a relatively small scale. So these prices, you may think they are not very large. So I'm a big fan of the empirical work, but I think the empirical work, what they cannot say is how high should that price be. So they can say, well, you tried with a price of 5% and then nothing happened, but then it doesn't answer the prospective question of, well, what would you tell to the policymaker about what to move forward on, and what is the price that you should have. So is that 5%, the tariff that is around percent, is it too little or is it too high? So how do the policymaker actually come up with that figure? So something else we did in the paper, we read a few review papers, a few policy documents, and we tried to figure out what is that policy. How do policymakers come up with that figure? So that's the best we could find. So there are some extracts from some policy document. So these are some quotes. So the optimal incentive size should follow the principle of not being too little, but also not too much. The size of the bonus is probably important in the pay for performance scheme. All else equal, the higher the revenue, the larger the response that you should expect, up to a certain point. So that still left me with, so after reading all these policy documents, that still left me unanswered with the question of how high should that price be. So just to sum up, so I took pay for performance and I covered three dimensions: theory, empirical evidence, and policy. So the theory gives you some pricing formula that can be quite elegant and general, but they may depend on some parameters that maybe are quite difficult to observe. The empirical evidence by nature is ex post, so tells you that, well, if you have chosen an incentive scheme that is up to 5% of the revenues, then that's not going to work, or it's going to have some minimal effect on process measure of quality. And the policy statements are intuitive, but at the same time they're a bit vague, so they don't give you like a clear idea of how that price should be designed. So I think this is the key example I want to give of where I think that there is a bridge to be built, so that these three areas come together a little bit more. So I think the more we can create some links between these three areas, the more it's likely that health economics is going to have an impact. So what I'm going to do next is to show my own application. So this is again one example of how you could bridge one of those gaps. So So instead of come up with a general model, we think about one application in particular, which is the best practice tariff for emergency stroke patients in the National Health Service. And the way this incentive scheme works is quite simple. So there is the usual basic DRG tariff. And then there are three dimensions of care for stroke patients that are incentivized. One is the rapid brain imaging. The other one is treating the patients in the acute stroke unit. And the other one is whether the patient is giving alteplase or not. So based on our reading, actually, this example is one where multitasking shouldn't be so much of a problem because basically all the main dimensions of care are covered. So potentially in this example, you could find the highest powered incentive schemes that you can find of because just by the design that should be the case. So how do the tariffs look like at the moment? So the basic tariff is for a stroke patient is around £3,000. And then for every patient that gets a rapid brain imaging, the hospital gets £400. That's his number here. If the patient is admitted in a stroke unit, that's another £1,000. And then if the patients get alteplase, then it's another £800. So these are the three. This is what the Department of Health is doing at the moment. So what do we do, which is, I think is a little bit unusual compared to micro theories normally reasoning in health economics, we kind of develop a model that mimics that setup. So rather than come up with a general model that would cover all possible pay-for-performance schemes, we say, actually, let's make the assumption that really mimic that specific applications. So we say, okay, there are three incentivized dimensions, and there is one that is not incentivized. Then the revenues for the hospitals are the sum of the prices for each of these dimensions times the number of number of patients that they get that treatment. Then we have to make some assumption about how the hospital behaves. And here we again take a conventional approach. We assume that the hospitals cares about the benefits of the patients, but also has to look at the cost and the profits, and we use, which basically goes back to a relatively old paper by Ellis and Maguire, who's over there. So I think this is like the kind of dominant way to model this thing. And then we come up with some formulas. Again, I'm not going to explain this in detail, so don't worry, Liz. But basically what those formulas says is that if you really try to calculate that optimal tariff, that depends on the marginal benefit of the incentivized dimensions of care, the three incentivized dimensions, the provider level, the provider's level of motivation, how much they were doing already without the incentive scheme, the opportunity cost of public funds, and the cost of the process measures. So the nice thing of the best practice tariff was that they were all designed in a way that they were based on clinical evidence. So if you have a chance to calibrate or to simulate this model, this is one of the best opportunities because the clinical evidence is there. So we actually went to look at the medical literature and looked at the nice guidance. Actually, to be fair, it's Soren who did all of that, which was an incredible amount of a job. And then we tried to recover what the evidence says about the benefits of these incentivized process measures. And we look at the quality gains that every patient has on average if they get in a stroke unit or if they get into alteplase. And then we translate that, we use like a monetary converter of the quality gains, which economists are used to do in some cases. And then we put it all back into the pricing formula, and that's what we get. So this is a hopefully nice diagram. So this is the degree of the motivation of the provider. This is the opportunity cost of public funds. So suppose that the hospital is really unmotivated, so that you really would have to incentivize them quite a lot. How high should be the price for a patient that is admitted in a stroke unit? Well, that's £25,000. That's a massive price. So what this says is that basically because the price reflects the marginal benefit of quality, that marginal benefit of quality is quite high. So this really suggests that you should have a very high-powered incentive scheme. Now, this is a bit extreme to assume that the provider is not motivated at all, and actually I don't believe that assumption, and I think that doctors are highly motivated. But if you push this down the line, where would you have to stop to get a tariff that looks like the one implemented by the Department of Health? Well, actually, it's around when the degree of motivation is 90%. So basically, what that suggests is that if you believe that the tariffs developed by the Department of Health are correct, then it means that the provider is already highly motivated, which actually raises the question why you want to really have this pay-for-performance scheme at all. The other way to read this is that, well, if you think that the motivation is not very high, then actually this tariff look quite high. So if you take already 0.7, then the tariff would be at least £5,000 just for the patient being added to the stroke unit. So what do we? This is a similar picture for patients getting altaplace. Again, it suggests high-powered incentive schemes. Let's keep that. So what shall we take out of this analysis? So we think that possibly this 5% is a bit too low. And that was the insight that we got from trying to calibrate this model and to put these numbers there was that actually, if you think about the theory and you put this in a specific context of best pay-for-performance scheme, that 5% seems low. So our policy advice would be actually you should increase that tariff because that's not enough. Or it could be that maybe we got the model wrong, and then then we should engage maybe in a more detailed discussions with clinicians to understand where we got the analysis wrong, because it could be that maybe we got the model wrong. But in a sense, this whole exercise I think is quite useful. But to do that, you have to be willing to make compromises on these different dimensions that economists work on, which is theory, data, and empirical evidence. So what are my conclusions here? So regardless of the fact that you like my applications or not, and there are many reasons for liking or not liking it perhaps. So my overall impression is that if we do a little bit more this kind of work, then I think there are some gains in terms of policy impact. Otherwise, the risk is that these three dimensions that economists work on, like the theory, the empirics, and the policy discussions, they remain independent and a little bit detached from each other. So in these specific applications I've provided, I think what we can do by engaging with this type of exercise is to provide some normative answers about policy design. So when the policymakers come around and ask us, well, can you tell us how to design that incentive scheme, we can actually provide a little bit more precise answers rather than saying, okay, well, there is this generic theory literature and then there are some policy evaluations, but then it becomes more difficult to put it all together. So I think this requires integrating. So I think this is hard work because you basically have to be willing to go one step ahead and really read all the clinical evidence, which perhaps for an economist is not the most exciting thing to do, and then maybe have more dialogue with the clinicians and the policy makers. So I think we should try to do this, and if we do that, maybe we'll bridge the gap between the health economists and decision makers.